Pretty sure you know that.
There we go. Okay. So this is the appendicular skeleton today. Next week, we will do the joints and articulations, and that will complete our survey of the bones. And we'll have a lab test come up. I'll probably open it up the the Tuesday after we come back after spring break. So and I'll leave it open for a week because it might be foolhardy to expect people to study extensively over spring break, but you could all fool me. I don't care. I'm fine. So, okay. Anyway, I'm hoping everybody can hear me, and I'm going to go ahead and open up this section on the appendicular skeleton. And there it is. Technology is amazing when it works. Okay. Now the appendicular skeleton is everything we haven't looked at. We looked at the skull, we looked at the axial skeleton, the vertebrae, the ribs, the sternum, and now we're going to take a look at the arms and legs, hands and feet, fingers and toes. And one of the nice things about this is that everything on the left-hand side of the body has the exact same name as everything on the right-hand side of the body. So if you learn one side, you learn the other side. So first thing we look at with the appendicular skeleton is the clavicle, our collarbone, if you will. Our clavicle, you can feel it right here. If you go to the midline of your chest and slide up to your shoulders, you'll feel this large round bump right above on either side of your shoulder, and that's the clavicle. You can see it here on the animation going around. And clavicle has two ends to it. It has a flat end and it has a thicker end. The flat end is called the acromial end. And here is now we have a flat end and a sternal end. And if we stop the sharing here for a second, and this is the clavicle right here, and you can see there's a flat end on the clavicle. Now there's also a thick end, and the thick end is the sternal end. The thick end is going to articulate right here on the sternum, because the flat end is going to articulate on our shoulder blade. So we have our sternal end, which is the thick end, and the acromial end is this flat end of our clavicle. But again, our clavicle sets right in here. It leads the way. It's easily broken because it's sort of out in front on our bodies. Back to the screen sharing. And you can even see here on this animation that the flat end is over here on our, let me get it to stop here for a second. The flat end of the clavicle is over here. This is the acromial end. This is the sternal end. And the sternal end of the clavicle tucks into the manubrium, the top of the sternum, on either side of the jugular notch. The jugular notch is this area right here. And so we have the sternal end fitting here and here, and you can see the flat ends out here. Now the flat ends are going to articulate with our shoulder blades, what we call the scapula, and they help to form a structure that is flexible enough to allow our arm to rotate almost a full 360 degrees. And it's almost like it's a hinge type joint. So let's get out of this and go on to the next. Okay, so we see, notice how the clavicle, setting at the very top there, coming off of the sternum, the sternal ends of the clavicle articulate on the sternum. The flat ends articulate on the scapula. Our scapula is our shoulder blade that you can feel if you take your arm and place, if you take your right arm, place it over your left shoulder, you're going to feel a spine there. That spine is part of your scapula, your shoulder blade. Same if you do it on the other side. The ability to rotate our arms and to move our arms in this full flexibility is based on this hinge-like structure that we get both at the sternum here, but also up here where the sternum and where the clavicle and the scapula come together. Okay, now, here's our scapula, our shoulder blade. No other bone looks quite like this. Let me see, we got a question here, hang on a second. The acromial end is the flat one. The sternal is the thick one. So the acromial end is the flat end. So, okay, good question. Now, here is our scapula. The scapula has a spine on it, the spine that you can feel when you reach behind. If you take your right arm and put it over your left shoulder, you can feel that spine back there. And that spine that you're seeing is this structure right here. This structure here, get this out of the way. The structure here is the spine of the scapula. And so there's a flat area above the spine, there's a flat area below the spine. The scapula is covered in muscles. Various types of muscles are found on the scapula. Most of the muscles are what we call the rotator cuff that allows us to have this flexibility in motion are found on the surface of the scapula, both the top surface and the posterior surface. Let's get out of this now. Okay, so first thing we see here, there is what's known as the infraspinous fossa. The infraspinous fossa is the flat area. Fossa means flat area. So the infraspinous fossa is the flat area below the spine. You know, these, instead of just saying flat area below the spine, we have to call it the infraspinous fossa. But it's this large flat area. And when we look at muscles, we're going to see that there are two very large muscles that sit right in there that help to control the motion of our shoulder. We'll talk more about that in a couple of weeks. Now, if we have an infra anything, we got to have a supra. And whether it shows up next or not, this flat area up here is called the supraspinous fossa. So there's our, I'll back some of these in a second, and I bet it won't show up in this. There it is. Nope. Nope. Sorry. I got carried away with myself. I do that a lot. So, okay. The infraspinous fossa. Now, the next thing to take a look at, according to the PowerPoint, is the glenoid cavity. The glenoid cavity is this flat area. If you have a scapula in front of you, you can see the glenoid cavity is this area right in here. Now, the so the glenoid cavity, if you're looking straight on at our scapula, is this structure right here. You know, here's our spine. Landmark is always the spine of the scapula. Here, this is the infraspinous fossa below the spine here, but our glenoid cavity is really the socket. It's the socket where the large bone of our forearm fits in here. It's where it articulates. It's going to look something like this. This is the humerus. This is the bone of the upper arm. The humerus is going to fit into the glenoid cavity like this. Now, it's not much of a socket. And if you look at it, it's just a flat area. In fact, it's often called the glenoid fossa. But the humerus fits in here. But the advantage of that flat area, that flat fossa, I said that right, the flat fossa, is that it gives us this incredible range of flexibility that we didn't have otherwise. So there's the glenoid cavity. Now, there is our spine, which I've mentioned a couple times. This little process here called the coracoid process comes off of the glenoid cavity. It's a point of attachment to various muscles. That's all you need to remember right now. Directly above it is the acromion process. This is where the clavicle articulates. So the clavicle, the acromial end of the clavicle is going to articulate here. So it's going to articulate flat end of the clavicle, flat end of the scapula. So it would look something like this. There's our flat end of the scapula, the acromial end of the scapula. There's our acromion right there, the flat end of our scapula, and they come together like this. So you would have this kind of structure like that. So flat end to flat end. Let's get back to this. So there's our acromion process. We have what's known as the vertebral border. The vertebral border is the side closest to the vertebrae. It is the long curve structure. This is the vertebral border for you can see here, and on the illustration here, you can see, you know, it starts at the level of the spine and goes all the way down to the pointy end. So that's the vertebral border or the medial border. It's closest to the midline of the body. The other border is the lateral border. That's the axillary border. That's the area closest to the armpit. So if you were to take well, I can bring him over here. Right, weird why I'm carrying it this way. There we go. Now, if we take a look at our skeleton, we can very easily see the sternal end of the clavicle here and the sternum. Over here is the acromial end of the clavicle. This is the acromial end of the scapula. This is the acromion. That thing's called the acromion. You can see where they articulate together on both sides, here and here, and then over here and over here. You can also see the coracoid process there, and there's one tucked away. I can get my hand out of the way. There's the other one right there. So, okay. Oh, good question. When you say the vertebral border is closest to the spine, are you referring to the vertebral spine or the spine of the scapula? The vertebral side. You'll notice that the vertebral border is this one right along in here, and it is closest, this is the side closest to the vertebrae over here, where the axillary border is the one closest to the axillary region. This area of the armpit is called the axilla. And so we have the axillary border right along in here, the side closest to the armpit itself. So now, Let's see if I can. This, okay, now. We have what's known as an inferior angle, and if we have an inferior angle, we've got to have a superior angle. The inferior angle is the pointy end of the scapula, and up here's the superior angle, the other pointy end. So, okay. And we have a superior border, and that means we have an inferior border too. So, important structures. The glenoid cavity is very, very important. It's the socket. It's not much of a socket. It's a flat surface, but its flat surface allows a great deal of movement. The socket we have in our hip for the femur, largest bone in our bodies, is a much deeper container and keeps our femur from moving around with the flexibility that we have with our arm. We don't get that kind of motion with our femur that we get with our arm and shoulder. But there's the glenoid cavity highlighted in green. There's the acromion, and the acromion is attached to the acromial end of the clavicle. It's attached and covered by ligaments and tendons. So it's a very flexible joint structure there. And there's a lot of give to it. So it acts a lot like a hinge to give us this range of motion. So, of course, there's the coracoid, that other process sticking out there. And you can see where the two acromial ends meet there too, and the sternal end there. But the coracoid doesn't do a whole lot for us in motion other than it's a point of attachment for muscles. If nothing else, a lot of these processes that we see sticking out, points of attachment. That's what they do. Transverse processes and spinous processes in the vertebrae, that's where muscles attach. That's, number one answer is always a place for muscles attach. So you won't be wrong. So now above the spine, we have the supraspinous fossa highlighted there in green. The supraspinous fossa, supra means above, and so it's the fossa above the spine. And again, there's a very significant muscle that you'll learn about that goes right in here. It's one of the rotator cuff muscles. There are 4 rotator cuff muscles. I don't want to get into that, but a very large and powerful muscle sets in that flat area. So these structures are not just bony structures that are isolated by themselves. They are covered in muscles that are going to do things for us. Another view of our scapula, looking straight down onto the spine. There's our glenoid cavity. There's the acromion process, the flat area. There's the coracoid process. There's the lateral or axillary border, because it appears to come right off of the glenoid cavity. There's the spine. The vertebral border is over here. There's the infraspinous fossa. The inferior spinous process, inferior spine. Supraspinous notch, I wouldn't worry about that notch. For one thing, it changes names a couple times on the PowerPoint. And whenever you have a notch like that, it's always going to be for a passage of nerves and blood vessels. There's the supraspinous fossa here, and over here is the vertebral border, right there. Okay. Looking at the posterior surface, we have one more big fossa we have to pay attention to, and that is the subscapular fossa. Many people get this mistaken on the bone test, and they say that the infraspinous fossa, and they get the infraspinous fossa and the subscapular fossa mixed up. Now, the infraspinous fossa has a big spine at the top of it. Infraspinous means the fossa below the spine. The subscapular fossa is on the underside. There is no spine in the way here. So when you are looking at this, for example, this is the subscapular fossa. no spine whatsoever. The infraspinous fossa, by its very name, is the fossa below the spine. There's the spine, there's the fossa. Just like the supraspinous fossa is the flat area above the spine, infra is below. If there's no spine, it's got to be the subscapular fossa. Subscapular means below the scapula. So this is the below the scapula area right in here. The only reason I make a big deal about that is I don't want anybody to get it wrong. Some people do. Some people mistake the two, and I want to make sure that you don't. So, because again, this whole section on bones has a lot more relevance to anything we've looked at so far, because knowing bone structures in the body is very important in a variety of areas of healthcare, surg tech, physical therapy, radiology, respiratory care. All these areas are going to, knowing the structures of the bones and then the muscles coming up, real practical applications. Okay. Now, there's that notch again. Superior angle, inferior angle, axillary border coming right off of the glenoid cavity, medial border coming off of the spine on the other side. That's a good way to remember it, I guess. Coracoid process, acromion process, and the glenoid cavity. Not good pictures on any of those, and that's this side. Because we're looking at the underside of the scapula. The underside is the part that rests directly on top of the ribs. It'll sit on your shoulder, on the back side of your body like this. So the flat side, we see it on our skeleton now. You can see very nicely. There's the spine of the scapula right here, the infraspinous fossa here. Underneath this, and you can see it better on this side over here. Let's see if I can get it a little further away so you can see it. There we go. There is the subscapular fossa there on the underside of the scapula. It sits on top, essentially sits on top of the ribs. It's the flat area. This flat surface sits on top of the ribs. Now there's muscles in the way, but that's what it does. That's why there's no spine on the underside. So, okay, let me get back to what I was talking about. Okay, another view of the subscapular fossa. No spine. There's that notch again. Superior angle, inferior angle, lateral border, vertebral border, coracoid process, acromion process, glenoid cavity right there. So let's move on to the large bone of the upper arm. And that large bone is called the humerus. The humerus is probably the third largest bone in our body. It is responsible for completing the joint with the clavicle and the scapula at our shoulder. Our shoulder joint is made up of the humerus, the clavicle, and the scapula. Now on this structure here, a couple of things that you're going to see right away. This bulge on the side is called, at the end here, is called the medial epicondyle. Now, I said last time that condyles are bony processes that essentially go up and down, like the occipital condyles on either side of the foramen magnum in the base of the skull. Well, because they're bumps of bone that move, they don't move, but they essentially have an up and down orientation. Epicondyles go out to the side. Now, epicondyles are going to bulge out on the medial and lateral sides. Now, how do you remember if this is the medial epicondyle or the lateral epicondyle? Well, the medial epicondyle, how do you know which is the medial side? Because you turn it around, it's all different. Look at the head of the humerus. The head of the humerus, the structure up here, let's just go through there we go. There's the head of the humerus right there. That's the head. The head is always on the medial side of the bone. The same applies to the femur. The head is on the medial side of the bone. If we look at our skeleton, you can see okay. There's our humerus right here, this bone of the upper arm. There is the medial epicondyle right there, facing towards the midline of the body. And here's the head of the humerus right here, also facing towards the midline. So the head of the humerus, the structure right there, that's the head of the humerus. And there is the medial epicondyle. I can't get it far enough away to really give you the perspective I want you to see, but the medial epicondyle and the head are on this exact same side. Now let's get back to this. So we have the medial epicondyle. If you have a medial, you got to have a lateral. So we have a lateral epicondyle. Why do we have a medial and lateral epicondyle? To hang on to muscles. We also have two sets of round structures here at the end of the humerus. We have what's known as the trochlea right there. The trochlea is right next to the medial epicondyle, and we have the capitulum right next to the lateral epicondyle. Those two little processes that stick out, the trochlea and the capitulum, allow us to move our arm back and forth. If you take your arm and stick it straight out and bring your hands up to touch your shoulder, you are using the capitulum, you're using the trochlea. If you can open a doorknob, if you can open a door, if you can turn a key, you are using the capitulum. So these two little processes here enable us to do amazing things with our arm. We can bend our arm, we can turn a doorknob, turn a key, turn a screwdriver, whatever we have to do, or we can keep flexing our arm all day long. There's also a big flat area behind the trochlea and capitulum called the Glenoid Fossa, and more on that later. Now, something else, we see a bulge on the side of the humerus. This is known, another word here, tuberosity. This is called the deltoid tuberosity. And a tuberosity is a point of attachment of a muscle. Anyone want to guess what muscle attaches at the deltoid tuberosity? Yeah, okay, so it's pretty obvious. It's the gastrocnemius muscle. No, it is it's the deltoid, the one you get shots in. You get your injections in your shoulder. That's the deltoid muscle. The deltoid muscle attaches itself to the humerus at its own special bump, the deltoid tuberosity, right there halfway down the side of the bone. Now, if we move a little further up, we're going to see two large bumps right next to the head. We have what's known as the lesser tubercle, and we have a lesser, we got to have a greater, and we do. The lesser tubercle is close to the head. There is an inner tubercular groove that blood vessels and nerves run through, because remember, bone is living tissue, right next to the lesser tubercle and adjacent to the greater tubercle. And we'll see a similar arrangement like this on the femur. We have a greater and lesser trochanter. at the head of the femur. Now, the head of the humerus is always going to be pointed towards the medial side of the body. So it's always in the medial side. Doesn't matter which perspective you have. If we flip the bone over, there's the greater tubercle, there's the lesser tubercle, the intertubercular groove. We flip the bone over to the other side. So now we're looking at the posterior surface of it. What we had before, let me go back one. There's the anterior surface. We flip it over. There's the posterior surface. It's still on the medial side. There's the head on the medial side. There's the medial epicondyle and the lateral epicondyle. Now we have a new structure here on the humerus. This is the Olecranon Fossa. Without the Olecranon Fossa, we have no elbow. We don't move, we can't move our arm. We can't bend our arm without the Olecranon Fossa. Like you can feel your elbow, but we all know where our elbow is. That structure that makes up our elbow, when it moves, slides into this fossa. This fossa is really more of a depression, if anything. So, okay. There's our trochlea next to the medial epicondyle. That means this is the capitulum over here, and this is the medial and lateral epicondyles. There's our head of the humerus again. Okay. The medial epicondyle, doesn't matter which side you're looking at it, it's going to line up with the head of the humerus. So it's always on the medial side. Now there are two bones of the forearm that are very distinctive. We have what's known as the radius. This is the radius. The radius has a round head that no other bone looks like. If you've got a radius, if you've got a bone in front of you with a sort of a round head like this, and I think you do, some of you do, it has to be you've got one attached to the hand right there. So this is the radius. The radius has a round head. Now, how do you find the radius? Well, if you can find your thumb, everybody has a thumb, I think. One of these is I want to find somebody that doesn't have a thumb. I'll feel really stupid, but that's beside the point. If you can find your thumb, the radius lines up directly behind your thumb, and it goes all the way to your elbow. So that's the radius. The radius is the bone that allows us to open doors and turn keys. So it has a round head right there called the head of the radius. It has a neck. A lot of these bones that have a head are going to have a neck the head's attached to. And right there is the neck of the radius. We also have another, it doesn't show up well in this picture, but this is the radial tuberosity right there. Now, if I can stop this for a second as it goes around. Take a look right here. That is you can see the round head, you can see the neck, there's the neck, and this little bump is the radial tuberosity right there. And then this little pointy structure down here at the bottom is called the stylus. Okay. Yes. The stylus, yeah, the stylus is right, the stylus is right behind your thumb. So it goes all the way. So if you line your thumb up, and right behind the wrist bones there is where the stylus is coming in. You can sort of feel it right there at the end of the radius. So there's the radial tuberosity. When we get into muscles in a couple of weeks, you're going to see that the biceps brachii, this big muscle that sits on the top of your arm right here, it attaches at the radial tuberosity. That muscle is what allows you to pull your hand up to your shoulder and pull your hand up. You know, it causes, we call it flexing the arm. So you bring your arm up, you bend at the elbow, and that's thanks to the biceps muscle pulling on that radial tuberosity. You can see them very prominent positions here. Now and there's the styloid process down at the other end. We had two styloid processes in the skull. We've got one on each radius. We've got one on each ulna. Here's a better picture of the. Now, this is what the radius does for us. This is a good picture here. This is a good animation. The radius is on top. Notice how the styloid process is right behind, lined up with the thumb. So you follow the thumb back, you can see where the styloid process is. The little pointy structure there. Let me. Okay, the styloid process is right there, and it lines up with the thumb. So, but notice how the arm turns over on itself. It rotates, and what's happening is the head of the radius is rotating around the capitulum. The capitulum is right here, because there's the medial epicondyle there, and that means this is the trochlea here, but this is the capitulum, and the round end of the radius will pivot around the capitulum. Notice that the capitulum has a more of a rounded surface to it, so it will pivot around that, so you can get this kind of rotating. Come on. There you go. It rotates over. Now, the bone directly underneath the radius is called the ulna. So if you know your thumb, and then you know that your radius is lined up right behind your thumb, the ulna is the other bone, the bone that's underneath there, the bone that doesn't move. You know, the ulna stays stationary pretty much because it has another job to do. But the radius allows us to turn our hand over. So like when we turn a key, when we open a door, when we use a screwdriver, anything, any kind of action, any kind of turning action is thanks to the radius, the head of the radius rotating over the capitulum. Another view of the radius. Here we can see the radial tuberosity. It's highlighted in green, but it's also this bump. There's the styloid process. There's the head. There's the neck. And there's the radial tuberosity right there. Now the bone directly underneath it is the ulna. And the ulna is another bone which is very, very distinctive. It looks like this. It looks like a socket wrench, if you will, more or less. That's the ulna. No other bone looks like this. If you want to know what your bone, where your ulna is, feel your elbow. When you feel your elbow, you are feeling this structure of the ulna, this round socket, this wrench-shaped structure up here at the head of the ulna. It's called the Olecranon process. So that round structure, round-shaped structure there is your elbow. And it's going to fit into the Olecranon Fossa on the humerus. I mentioned that's the reason why I mentioned that before, not because I like saying Olecranon. But the Olecranon process is the elbow that we all feel right here. And so, you know, no other bone looks or feels like this. But it gives us, this is the bone that gives us the ability to flex our arm or extend our arm at the elbow. You know, we can bend it towards us, we can bend it away from us, thanks to the Olecranon process. Now, the structure here called the Coracoid process, that's called the trochlear notch. It tucks itself on top of the trochlea. So that the capitulum is what the radius uses so it can rotate itself. The trochlear notch sits on top of the trochlea So it gives the ulna something to slide over as it moves back and forth. And there's its styloid process. Now, and one thing about the ulna and the radius is that, if you know your thumb, you can find the radius and the ulna. I tell the A&P2 people that if you know where the radius is, you also know where your radial artery is, because it's running right underneath the radius. And that means you know where your ulnar artery is, because it's running right underneath the ulna. And if you know that, you know where the ulnar nerve is running, which runs right underneath the ulna. And you also know where the veins are. So with just knowing your thumb, in addition to knowing, all those, 2 bones and 4 blood vessels and 2 nerves, and you also know where your pulse, one of the places to take your pulse is we take our radial pulse at the radial artery right behind the thumb. So, this stuff isn't rocket science. It just, it just requires a certain level of memorization, but it does all fall together. Now, there's the ulna. No other bone looks like the ulna. No other bone looks like the radius. So here we have a cluster of bones in the hand. The hand has the fingers are called the phalanges. The bones of the hand itself are called the tarsal bones, the metatarsal bones, and the bones of the wrist are called the tarsals. So there's, the carpals, the metacarpals, and the phalanges. The bones of the foot are the tarsal and metatarsal. Phalanges. Now, the good news about this is that the same name for the fingers is the same name for the toes. The toes are called phalanges also. Phalanges are phalanges. We have carpals here. In the foot, we have the tarsal bones. We have the metacarpals here. We have the metatarsals in the foot. There are 8 bones in the wrist, and I'm going to run through the name of them, but I'm not going to ask you to be able to identify them because, frankly, they're never going to look as good as they do in these pictures. So, but we have the trapezium, trapezoid, scaphoid, capitate, hamate, lunate, triquetral, and pisiform right there. And there's no good way to memorize those. So I just say that those are the carpal bones, the bones of the wrist. So they fracture easily, particularly in older people, because when an older person falls, well, when any of us fall, what's the first thing we do? Put our hands out, right? Well, an older person, when they put their hands out, their bones are not as strong as they used to be. And so it's not unusual for an older person, as they fall, to fracture their wrist bones. And it's usually gets a little, requires surgery because you've got 8 little bones in there that can be all mixed together. And so we don't like to see that. So, okay, now, and there are the 5 the metacarpal, I had to stop and think for a second, the metacarpal. Okay, so now we're moving down into the lower end of the appendicular skeleton. We've gotten rid of the shoulder and the humerus and the ulna and the radius. Now we're down to what we call the pelvic girdle. The shoulder was called the pectoral girdle. This is the pelvic girdle. And we see right away that we're looking at the hip bones. This is a female pelvis. Now, how do I know it's a female pelvis? Well, besides the fact it says so, the giveaway is the shape of this angle down here at the bottom. The female pelvis has a an inverted bowl-shaped depression here. It looks like this. This is an inverted bowl. This is a female pelvis right here. And just so that everybody sees it. Okay. This is a female pelvis, and you can see the inverted bowl shape is this structure in here. Now, a male pelvis is, instead of being an inverted bowl, is going to be an inverted V. It's going to be a much narrower opening in through here. So, and that's what you would see on the skeleton. And you can see there, notice right there where the stand is, that's an inverted V structure. The male pelvis is much narrower in that particular shape. So that's how you can tell them apart. Another very quick and easy way to identify it is, can you put your fist?
The camera is about to tip over. Hold the cable down the tripod. Just want to make sure nothing happens.
Okay.
Sorry.
He's showing off because he hasn't been here for a while. So, okay. Thank you for pointing that out. Now, I'll start throwing things at you in a minute. Okay. How do we know that this is a female pelvis? Well, another way to take a look at it is if your fist can go through this cavity here, this space here, because in a male pelvis, it's not wide enough. The space between the edges, the brim from side to side, here to here, is not wide enough. This has to be wider to accommodate the passage of a baby from the birth canal. So your fist is about the size of a baby's head. If it can go through with no problem, it is a female pelvis. Now, having shared that little piece of information with you, don't try and think about when you would figure something to have to use it, since most people are still attached to their pelvises. But if you were to encounter if you're working in a forensic lab and you have a skeleton that's brought in and the skeleton is mostly intact, one of the first things you would look at would be, is it an inverted bowl or is it an inverted V? Is it the narrower opening? If you can, and you're feeling bold, you can try and put your hand through the opening. That's pretty definitive in looking at the skeleton, particularly if other structures are missing, like if the skull's gone, for example, because the skull is very distinctive too. So anyway, so this is our female pelvis. The large bone there is called the ilium. There's one on each side, and at the top of each ilium is what's known as the iliac crest. And the iliac crest is, if you've got a hip bone out there, somebody may have a hip bone. The iliac crest is, if we look at our skeleton, it's this area right here. Now, without having to tear this apart, if you want to know where your iliac crest is, if you go to the side of your leg and about the level of where your pockets are, come around to the side just behind the pocket, and you'll feel a bump right about here. That's the iliac crest. That's the top of the ilium right there. It's a very good landmark because that tells us also where the muscle is when we want to have an injection in our hip. We don't get shots in our gluteus maximus because there's a great big nerve underneath there that we don't want to hit. We get injections in our gluteus medius. And the landmark for the gluteus medius is the iliac crest. And you can feel your own iliac crest right there. It's sort of about halfway down your pocket, back about 2 fingers. And that's where your iliac crest is located. There's the sacrum. There's the pubic bone, the ischium. And so we see that the pectoral girdle is made up of 3 bones on each side, the ilium, the ischium, and the pubis. We have a connection, a joint between the ilium and the sacrum, the end of the spinal column. When we walk, the shock of motion comes up our legs. It goes through the ends of the femur into the ilium at this structure here, which is called the acetabulum. That's the socket, if you will. We'll see it labeled here in a second. The shock is carried around to the back side of the pelvic girdle. It comes to the sacroiliac joint on either side of the ilium and then is transferred up the spinal column where those intervertebral discs, these pads here, absorb this shock of motion. So it doesn't hurt when we walk and run and climb stairs or ride a bicycle or swim or do anything like that. At least it's not supposed to. The shock of motion also comes around the front and it hits this pad of cartilage right here. This is called the pubic symphysis. That's the other shock absorber. So as we walk, we aren't aware of the stresses that we're placing on our bones because we transfer them from the long bones of our legs to the pelvic girdle and then up our spinal column through the sacroiliac joint into these big intervertebral pads, as well as the pubic symphysis in the front. Yeah. And there's the pubic symphysis right there. This big opening here is called the obturator foramen. The obturator foramen is, well, you know, a foramen is a large hole. The obturator foramen is the hole that we have to allow very large blood vessels to move from the abdominal cavity into the legs. And so they go through the obturator foramen, as well as very large nerves that run down the leg. So this is a passageway here because our large blood vessels are going to start subdividing right about the level of the obturator foramen, so they can go down our legs and down to our feet. So they pass through that opening there, as well as many nerves. Lumbar vertebrae. There's the acetabulum. That is the socket for the femur. And there is the pubic arch. The pubic arch is the identifier. The pubic arch is what's telling us, is this a male or a female? In the female, the pubic arch is an inverted bowl shaped. In a male, it's an inverted V, because the male pelvis doesn't have to be as large because the male doesn't have babies. So now, female pelvis. There's the coccyx. There is the what we call the true pelvis, the brim to brim, in that area where I was showing you, where you could place your fist and try to pass it through this opening. The brim to brim area there is going to be much wider in a female pelvis than in a male pelvis. There we have what's called the false pelvis. We go from iliac crest to iliac crest. And we have the pelvic brim. So it's the pelvic brim around the edge of the true pelvis that decides the width here. Okay, and here in the pubic arch. Now we look at the back side of our pelvis, the posterior side. Again, we can see the sacrum and the coccyx. There's the ilium. There's the ischium. There's the pubic bone, one on each side. You know, there's the pubic arch, and right in the middle is the pubic symphysis. There's the coccyx, the iliac crest up there. There's a little spine on here and the ischium on each side. Now, if we look at, you know, if we look at the coxal bone, which is a combination of what we call the hip bone with the ilium, the ischium, and the pubis, we can see that all three of them combine to form the socket, the acetabulum. There's the ilium, there's the iliac crest, anterior superior iliac spine, and so on, inferior spine. There is the acetabulum. All three bones come together to give you this socket. This socket is very deep. It is much deeper than the glenoid cavity. The glenoid cavity is just a flat surface, but our socket here is deep enough that the head of the femur can fit in there very nicely. That's the acetabulum. There is the pubic bone, and that opening again is the obturator foramen. What I've been building to is this very large notch right there. It's called the greater sciatic notch. At the greater sciatic notch, a very large nerve made up of thousands of individual neurons, about the size of the whole nerve is about the size of your thumb, the thickness of your thumb. It comes out from below the spinal cord, runs down your leg, behind your knee, and goes all the way to your great toe on both sides. And this is a sciatic nerve. There's a smaller branch of it that joins into that just below the lesser sciatic notch. This nerve is often, inflammation of this nerve is often the cause of a condition known as sciatica. Many older people experience sciatica where constant pressure for years on their hip, for example, inflames that nerve. And the thing about that inflammation is that the pain can travel down the leg and appear to be radiating from the ankle. It can appear to be localized by the knee. It can be at the hip. And it's often caused by direct pressure, sometimes as simple as 50 years of someone carrying a very thick wallet on one side or the other and sitting on it during the day. Or sitting on, or just sitting all day in whatever they do. They have a very sedentary occupation. They sit most of the time and they put pressure on their hip, and that pressure inflames, over time, inflames the sciatic nerve. Sometimes people will have difficulty sleeping on one side or the other. If they are a side sleeper, they sleep on one side until it hurts, and then they have to roll over to the other side. It's because of simple pressure on the sciatic nerve. It's simply because the nerve gets inflamed. And one of the reasons that we give injections not in the butt, but off to the side, is because the sciatic nerve runs down right across the middle of the gluteus maximus. And if you were to inject a syringe into that nerve, it's going to be a whole new experience and pain for your patient. So we don't do that. Whenever you've gotten a shot in the butt, you've got usually antibiotics and steroid shots. You go to your doctor, you get an antibiotic. It's nearly always going to be here. Flu shots and flu vaccines and stuff like that you get in your shoulder, but antibiotics go in here. Well, they don't go in your butt; they go off to the side of the gluteus medius. So that's why we use that landmark of the iliac crest, because you don't want to cause any pain like that. So imagine having dental work done without Novocaine. Slow dental work done without Novocaine. Think about it. Some of us have to be Novocaine before they get out of the car, but I won't say who. So, not that I don't like dentists, but I just don't like what they do. Okay, moving on. I'm not disparaging dentists. This is the largest bone in the body. This is the femur. And you can see it's a very large, powerful bone. Some of you have femurs out there. We all have a femur, I think. But you can see how big it is. You can tell a lot about the femur. You can tell the age and the size of the individual just by evaluating the length of the femur. There are some very simple procedures that anthropologists will do if they only have a femur. They can give you a pretty good estimate of the size of the individual. Now, this bone takes a lot of stress because the stress and shock of motion has to come up the femur and be transferred into the neck of the femur, which is this structure right there. There's the head, and the neck is right below it. So a lot of our shock is transferred up this very powerful bone, up to the neck, up to the head, into the acetabulum, around to the sacroiliac joint, and up the spinal column. Now, when we get a little further along in lecture, we're going to see that the bone that's underneath here, the outer layer is very powerful. We call it compact bone, but it's only a thin layer. underneath that is what we call spongy bone. It's lightweight bone, just as strong, but lightweight, and it's flexible. It allows for stresses to come from all different directions. So when we move our legs, doing whatever we're doing, the stress of motion can come in any direction and it's not going to upset anybody. However, the spongy bone underneath here is prime turf to be eaten by osteoporosis in older people. So when grandma breaks her hip at the neck of the femur. She doesn't break her hip. She breaks the neck of the femur because all the bone underneath it, except for the outer shell, has been eaten away. So, and why do I say grandma? Because osteoporosis nearly always affects females, postmenopausal females. So here's my chance to throw grandma under the bus. Postmenopausal females aren't producing estrogen. Estrogen stimulates bone growth. No estrogen, very little bone growth after menopause. And so if grandma didn't take care of herself before menopause, getting a lot of calcium in her diet, a lot of exercise, a lot of protein, she's going to be a candidate for osteoporosis later in life, fairly soon probably. Whereas a postmenopausal female that had lots of calcium in her diet, lots of exercise, still exercise, get lots of protein, she may be 80 or 85 years old and not even have a hint of osteoporosis taking place. So be that as it may, when an older person breaks their hip, it's nearly always going to be the neck of the femur where it happens. So anyway, okay. There's a large bump on the head end of the femur called the greater trochanter. This is the counterpart to the greater tubercle on the humerus. You'll notice it's on the lateral side. It's on because the head's always on the medial side on the femur also. So the greater trochanter is on the lateral side of the femur. That means that the lesser trochanter, which just happens to be this one, is on the medial side. Points of attachment for muscles. And there's an intertrochanter, like there was a greater intertubercular groove. Here we have an intertrochanteric line. Now here we have the medial epicondyle, just like we had in the humerus. It's on the same side as the head. That means there's a lateral epicondyle right there. Now we have some condyles. At the proximal end, there's the head, there's the greater trochanter, the lesser trochanter, and the intertrochanteric crest. But down here on the distal end near the knee, we have the medial condyle and the lateral condyle. Now we still have the epicondyles on either side, but here we have the medial and lateral condyles. They are what those pads of cartilage in our knee joint sit on. And when we have, because we have cartilage in our knee, we hear about, you tore your cartilage up in your knee, you had to have arthroscopic surgery because you tore up your cartilage. The medial and lateral condyles rest on pads of cartilage that sit on top of the tibia. And so that's what the medial and lateral condyles do for us. Okay. Now, speaking of the knee, there's our femur. There is our patella. I had a patella. Well, my patella is missing. Okay. Patella, it's about the size of half of a walnut. It's, you can feel your patella. You can reach down to your knee and you can flex your patella at the knee. It is suspended in a tendon. It attaches from the end of the femur to the top of the tibia. There is the fibula, the most useless bone in our body. It does nothing for us except get broken at inopportune times. in contact sports and skiing and things like that. It is not a load-bearing bone. It has nothing to do with movement. It just sort of sets out there and says, here, break me. And that's what happens, you know. I had a orthopedic surgeon once tell me that his two bread and butter injuries that he made all of his money on were broken fibulas in the wintertime and broken thumbs in the summertime. So everything after that paid all the bills. He did everything else for fun. So because it just sort of sets out there, it doesn't do anything for us. Now the other bone of our leg, which does all the heavy lifting, is called the tibia. It is the large bone of the lower leg. And we'll talk about both of these here close up now. There's the tibia. And of course, there's the medial and lateral condyles. There's the lateral condyle on the tibia. There's a lateral condyle on the femur. And there's a medial condyle on the femur and a medial condyle on the tibia. This space in between here is where these pads of cartilage called the menisci go. And so the condyles of the femur rest on the pads of cartilage, which are setting on top of the condyles of the tibia. Okay. Yeah. Okay, here's our fibula. This is a fibula right here. It's very hard to tell which end is up. If you look at the fibula there in the illustration, it's hard to tell which side is which. That's the head. I would have said that was the other end because I wasn't looking at it right. But one thing about the fibula, its one claim to fame is it is the outside of our ankle. If you want to touch the end of your fibula, reach down to your foot and touch your ankle on the outside. Now, there is no bone called the ankle bone. What you're touching on the outside of your foot at the level of the structure we call the ankle is called the lateral malleolus. And that the fibula comes down and fits on top or fits around the large bone in our foot. Now, that's all it does. It is the outside of the ankle. When people experience ankle injuries, it's nearly always going to be an injury on the lateral malleolus because the fibula is weak. It isn't attached to any other bones. It doesn't have it's not supported well, and it just sort of gets in the way. Now, the tibia is the hard working bone of the lower leg. The tibia, the most prominent thing we notice about the tibia is the anterior crest. And if you rub your hand down across your lower leg on your tibia, you're going to feel a sharp edge as you go down that leg. We often call that our shin bone. You know, our shin bone was designed to discover things for us in the dark, like tables and chairs that we didn't know were there. Sharp edge. And it's a great landmark for identifying muscles of the lower leg too. But there is the anterior crest of the tibia. And you can feel that. You can feel it. You rub your hand down across your leg, down where the so-called shin bone is located. You can feel that sharp crest. Now there's our tibia. We also have a malleolus here. This is called the medial malleolus. This is the other side of the ankle. The medial malleolus is on the inside of your leg. So it lines up with your big toe. Another thing, another one of these landmarks is your big toe is always on the medial side of your body, of your leg. Whichever leg you're looking at, left leg, right leg, doesn't matter. The big toe is always on the medial side. That means that the ankles on the same side as the big toe are going to be the medial malleolus of the tibias. So the tibias make up the inside portion of the ankle structure. The fibulas make up the outside portion. The strength is on the inside. I'll just tell you that. So there's your medial malleolus. There's your medial condyle and your lateral condyle on the tibia. And of course, there, as I said, there are pads of cartilage that are going to sit on top of these condyles. You know, again, There's the anterior crest, and the tibial tuberosity is where the tendon that holds the patella attaches to the tibia. And there is, again, our medial and lateral condyles right here. And the pads of cartilage would set there and there. Now here's our foot. The foot, the toes are called the phalanges. Behind the phalanges, we have the metatarsals, and then we have the tarsal bones. So here are the phalanges. Here are the metatarsals, and behind the metatarsals are the tarsal bones. And here we're going to name them because these are pretty easy to remember. 3 of the bones have the same name. We have what's known as the medial cuneiform. It's right behind the big toe, if you will. We have the intermediate cuneiform, which is right behind the second toe. And we have the lateral cuneiform, which is behind the third toe. And then we have behind 1 and 2, we have the navicular bone and we have the cuboid bone. That leads us to these other 2 large bones here, which are very, very important to us. We have what's known as the calcaneus and the talus. This is the talus. And the one behind it is the calcaneus. Now the calcaneus is the bone that forms our heel. Our heel bone is the calcaneus. And if we bring our skeleton up here a little bit. I didn't say everybody didn't have flexibility there. Let's take a look. Here is our, here's our foot. Let's round up, knocking him over. Okay, there's our foot. We can see these are the phalanges up here. We have the metatarsal bones here, and these are the tarsals. We have the medial cuneiform, intermediate cuneiform, lateral cuneiform. We have the navicular and the cuboid, but more importantly, we have, spin around, there we go. Here we have this large bone here is the calcaneus. Turn it around, there we go, that's the calcaneus. That's our heel bone. That's this large bone at the heel of our, back at the very heel of our foot. But above it is this bone called the talus. You can just sort of see the talus. There's the calcaneus, there's the talus. Now notice at the talus that you've got 2 large bones coming here. This is the tibia here and the fibula over here. This is the lateral malleolus here and the medial malleolus here. So the ankle is made up of the talus and the talus and the lateral malleolus and the medial malleolus. There is no ankle bone. The 2 bones simply, the tibia and the fibula simply come down on either side of the talus, because there's the talus right there. There is the fibula there, and over here is the medial malleolus there. So, and they're only held together in place by ligaments and tendons. So it's not like a socket or anything there. And so if an individual sprains or strains their ankle, they are tearing those ligaments or tendons at that particular type of joint. It's that joint has limited flexibility, and we don't seem to have any problem tearing it up. Back to this. Okay, so there is our navicular and our cuboid. Let's go here to this side view here. Now here we can see, looking at the foot, there is our, because this is lined up right against, same lined up with the big toe. This is the medial cuneiform right there. There is the tibia there. That means this is the medial malleolus here. The fibula is sort of tucked away back over here. You just sort of see the edge of it there. And you can't see the lateral malleolus. This is the talus right there. And then this is the calcaneus here. The calcaneus is where our Achilles tendon attaches. That allows us to raise our heel when we walk. We can raise our heel when we take a step. And so we bring our heel up, and that's the Achilles tendon pulling on that. So, okay, and there is the cuboid tucked away there. So, okay, and that is the appendicular skeleton. Are there any questions? Get out of the sharing stage here. Anyone have any questions on anything? Okay, then I'm going to get us out of here, and I'll have this posted right away.